Good afternoon and welcome to the City Club of Cleveland. I'm Hugh McKay. I'm president of the board of directors of the City Club. Today's speaker, Dr. Thomas R. Insel, was born in Dayton, Ohio, and proceeded to redefine precocious. Earning his Eagle Scout badge just a few days after turning 13, the youngest ever to do that, beginning college courses at age 14, leaving high school at age 15 to enroll in the Boston University Combined Pre-Med Medical Program, where he focused on English literature. By age 17, having completed most of the requirements for his pre-med degree, and still below draft age, Dr. Insel began exploring the world. He hitchhiked across Canada and through the West, got married at 18, then traveled with his wife, to whom he is still married today, around the world, stopping to work at a tuberculosis clinic in Hong Kong and a mission hospital in India. Seems like he could have retired by age 20, but he remained precocious and remains so today as director of the National Institute of Mental Health. With a budget of roughly $1.5 billion, the NIMH leads the nation's research on disorders that affect an estimated 44 million Americans, including 1 in 5 children. Immediately prior to his appointment as director, which marks his return to NIMH after an 8-year hiatus, Dr. Insel was professor of psychiatry at Emory University. There he was founding director of the Center for Behavioral Neuroscience, one of the largest science and technology centers funded by the National Science Foundation, and concurrently he was director of an NIH-funded Center for Autism Research. He's published over 200 scientific articles and several books. And just as of 2 months ago, January 1st, Dr. Insel was honored by me being named director of the new National Center for Advancing Translational Science. He was named by Dr. Francis Collins, head of NIH, who spoke here not long ago. Dr. Insel has served on numerous academic, scientific, and professional committees, including 10 editorial boards. He's a member of the Institute of Medicine, a fellow of the American College of Neuropsychopharmacology, and is a recipient of several awards, including the A.E. Bennett Award from the Society for Biological Psychiatry, the Kurt Richter Prize from the International Society of Psychoneuroendocrinology, the Outstanding Service Award from the U.S. Public Health Service, and many other awards. Dr. Insel's tenure at NIMH has been distinguished by groundbreaking findings in areas of practical clinical trials, autism research, and the role of genetics in mental illness. During his tenure, NIMH has become a leader in global mental health issues in groundbreaking partnerships with the World Health Organization and the Global Alliance for Chronic Disease. Please welcome to the City Club of Cleveland, Dr. Thomas Insel.
Well, thank you very much, Hugh, for that introduction. There's no way I can possibly live up to that. And I have to say that by way of really framing what you've just mentioned, I was equally impressed when I looked at who has been speaking at the City Club. It's really an intimidating group of speakers that I'm coming to follow. I actually had to confess, I was talking to my wife about this, and I said, look at this list, you know. Bill Clinton, RFK spoke here, Rosa Parks, I mean, extraordinary, Cesar Chavez, John Glenn. I said to her, in your wildest dreams, did you ever think that I would be giving a speech to the same group that all these famous people spoke to? And without missing a beat, this is the same woman I was married to since I was 18, she said, you know, sweetheart, in my wildest dreams, you're never around. So, I have an awful feeling that that's the only thing I'm going to say that you'll remember. But I did actually come to tell you something else, which was start by letting you know that I'm here from the government. I'm one of, and this is a year when we're talking a lot about government and whether government should be bigger, smaller, more efficient. What is the role and you'll hear a lot about this. I know there's a primary here coming up in a very few days, and this will be part of the national discourse between now and November. So I work for a part of the federal government called the National Institutes of Health, and that is something that all of you support through your taxpayers. We have a budget of about $31 billion altogether. We've been around since, in the form that we exist now, since the 1940s. And our role is rather unique. There are very few countries that have done this. The United States had decided that it would create this agency which, to some extent, funds research, to some extent does the research at the NIH as well. But fundamentally what we're about is trying to take the most important problems that face us in science and in healthcare and to innovate around them. So we want to make fundamental discoveries about biology and behavior. And then our task is to take the next step and make sure that those fundamental discoveries become breakthroughs for health. And it turns out this is much harder than we thought. And it takes a lot of very smart people and a lot of very creative ideas and a lot of innovative approaches to be able to make opportunity here really pay off. Now, we have done this in a whole series of different areas, and I know that Francis Collins was here recently, so he probably has, for many of you, talked about what that means in terms of genomics. And I want to spend just 5 minutes maybe telling you, in terms of this piece that has to do with fundamental discoveries, why that right now is so exciting. We are in the middle, absolute middle of a revolution in science that is giving us what we sometimes call breakthrough technologies. Now, that's not the same as saying breakthroughs in health, but breakthrough technologies allow us to do things in a way that before we could only imagine, and sometimes we couldn't even imagine. Let me tell you about two areas. The first is genomics, which is a little different than genetics. You'll hear a lot of this, and it's often in the paper, the omics. This is the omics revolution, the omics era. All that is, you take whatever area of science you're interested in and you put O-M-I-C on the end of it. But what it really means, as Dr. Collins might have said, is that for the first time we're able to do what we call comprehensive science. Omics is comprehensive science. That is, any science that has, when you try to explain it, has the word all in the sentence. And genomics is about doing studies that take into consideration all of the genes in the genome. We can do this in a way today that we couldn't do it a decade ago. About 10, actually almost 11 years ago, we had the Human Genome Project, which was then completed. And we thought, with Bill Clinton's announcement and Francis Collins, who drove that project, we thought we really were, at that point, kind of closing a chapter in the study of human biology. Little did we know that that was the very first chapter of a very long book. What we had at that point was the first map of a person's genome. And what we didn't understand was the enormous variation that each one of us carries with us. What we also didn't know was the importance of being able to do this with new technologies. And what we can now say 11 years later is that probably the most important breakthroughs that came about from that project and the work that's gone on since hasn't been so much the discoveries as much as the innovations, the tools that have been developed that allow us to do sequencing of the whole genome faster, cheaper, and better. 2002, 2001, when the project was completed, if you wanted to sequence 1 million bases of DNA, and there are 3 billion bases, so 1 million isn't that much, it would have cost you $5,285 and would have taken you several months. Today that costs 19 cents, and it would take you a couple of hours. The first human genome in the Human Genome Project cost us about $3.5 to $4 billion. If Dr. Collins was here, he'd probably say, no, not quite that much. But that's about the right figure. And under his leadership, it took about 10 to 12 years, which I think he would admit was probably even a little bit ahead of schedule. Today, if you wanted to do a human genome from any one of us, you could do it for close to $1,000 instead of $3 to $4 billion, and you do it in the matter of a couple, 2 to 3 days. So we are in a very different realm of accelerated opportunity for being able to understand some important things about our biology, which comes out of the Human Genome Project. Some of those things have to do with how are we different from all other species? What makes us human at the genomic level? Some has to do with the history of human origins and human migration. And a lot of these really interesting questions are beginning to be answered. Some of it, of course, has immediate applications to the legal system, and you don't have to watch more than one episode of CSI to hear about the importance of genetics or genomics and knowing how to find the culprit. But from a biomedical perspective, it's still very much a challenge to take those breakthroughs and to turn them into breakthroughs for health. We had a spectacular example last week that comes out of work that was done here in Cleveland at the Cleveland Clinic that had to do with cystic fibrosis, a disease actually that, again, Dr. Collins was the person who discovered the gene for cystic fibrosis. It turns out that it's one gene, but there are hundreds of mutations that can affect that gene to lead to this terrible pulmonary disease of childhood. The breakthrough recently was the FDA approval of a new drug for cystic fibrosis. It affects only 4% of people who have the disease, and for them it's virtually a cure. But the power of genomics has allowed us to identify that 4% very predictably. We can identify that though we've called this disease cystic fibrosis, it's many different diseases, at least many different causes, and we can, using this very powerful high-throughput sequencing technology, identify who has that particular mutation and who will respond to that particular disease or that particular intervention. So genomics has gone through, by any definition, a revolutionary advance because we can go so much faster, so much cheaper. And in fact, increasingly, this is becoming what we call the age of recreational genomics, where any one of you can spit into a cup and send saliva to a company that will send back within a matter of a couple of days everything you'd want to know about your ancestry and about who you're related to. I did this a few years ago, and they told me that I was related to John Adams, which I guess is completely improbable, but on the other hand, we're all related to John Adams, so maybe they could get away with that. There's another area which I think is, again, changing the face of how we think about human biology and human health, and that's in this vast area of human imaging, or high throughput and high resolution imaging. In a way, this is the one that's probably more relevant to what I really want to tell you about, which is mental illness, because this allows us, for the first time, to have technologies that take us into the brain. And in a sense, what it's doing is what we had already seen for 3 centuries, the development of optics and telescopes that have helped us to explore outer space, is now going the other direction. So we're getting these very high resolution devices that will allow us to explore inner space. And to do this with a precision which is mind-boggling. And literally, I use that term because today, increasingly, we can use brain imaging to study the mind in a way that you could hardly have imagined 3 or 4 decades ago. When we do this, we can begin to, just like with the genome, understand human variation. We can begin to understand brain variation in new ways. And there's another ohm that comes here. So instead of the genome, the new ohm that goes with imaging and the brain is called the connectome. There's a great interest right now, and you'll hear a lot more about this in the next year or so, in being able to define the human brain, the whole wiring diagram. The human brain is essentially a very cool computer. It's a computer that not only consistently changes its software, but it on the fly can change its hardware. And it can do this in a way which we just barely understand. You've got 100 billion neurons in your cortex, and every one of them has 1,000 connections. I'm sorry, 10,000 connections on average. And for those of you who think, well, so a billion here, a billion there, so what? Let me give you a sort of reference for billion, what that means. If you convert, instead of talking about neurons, you think about what's a billion seconds. A billion seconds is about 31 years. So if we're talking about 100 billion of anything, that takes you back a ways. So here we've got this enormous complexity which up until now has been a bit of a black box. But for the first time, we can begin to see inside that black box, and we can look at who has more or fewer cells for a particular brain area. And it turns out, for instance, that when you study the area of the brain that's really important for location and geographic memory, that amazingly, taxi cab drivers in London beat anybody else in terms of the number of cells they have and the amount of brain territory that's devoted to representing location in space. That's pretty cool. Musicians have a much more developed auditory cortex. Maybe that's not so surprising. And other kind of bizarre things, like when you study people who are totally blind from birth, they still have a visual cortex, but that visual cortex is used to decode auditory signals and non-visual ones. So this brain is enormously plastic, enormously adaptable, and enormously flexible to do any of the things that it's asked to do. What we've begun to understand from the kinds of imaging we can do today are two things that were just completely unexpected. I think we kind of expected the flexibility, at least some of us who were optimistic. Maybe we shouldn't have, but that's been good news. What we hadn't expected is the way that the brain is organized, because it doesn't make any sense to us, or almost any sense to us. So there are categories within the brain and the way that the brain is organized. You have, for instance, a different area of the brain that's representing tools from the part of the brain that represents animate objects. Maybe that makes sense. Not the way I would have designed it, but that's just the way it seems to work. You have a large part of the brain that's very important for decoding faces, and one area that's important for face emotion and another for face memory, and they barely overlap, but luckily they do talk to each other. So one of the kind of stunning things about the way the brain is organized is just this kind of heavy categorization at the same time that there's a lot of flexibility and adaptability. The other, which is completely unexpected and is still sort of sinking into our consciousness, is that the brain appears to be most active at rest. Now that just seems weird to me. But if you do these fMRI scans and you put people into scanners with very high resolution, we've been doing this for a long time, and you give them all kinds of tasks. You give them a mental arithmetic task, or you give them an emotional task, or you give them even a finger tapping task. You can see very reproducible activation patterns for those areas of the brain that are important for those tasks. But if you just put people in the scanner and say, just chill, just take a few minutes and chill. If you want, we could even put on a little bit of soft music. Suddenly what you see is a very active cortex, except that no two of us have exactly the same pattern of activity. And just as the world of genomics has told us how much variation there is in the human genome, now the world of what we call resting state imaging for the brain is giving us a sense of just this extraordinary variation in what we do at rest, how our brain is active, and in addition, how our brain is wired, where again we're seeing enormous variability. Sometimes that's meaningful, sometimes it isn't, but there's no question that as the science gets better and as our ability to see brain structure and brain function in a very precise way becomes more mature, we will have a much, much better understanding of the mind. Because instead of having to rely solely on our reports of what is going on, we can begin to ask the organ of interest itself, what is it that you're doing? What is it that's happening in real time? And begin to make sense of that on an individual level. Now, all of this would give any of us lots of hope, because you can say, my goodness, we have really now got in hand the capacity to make big advances for health, to take that NIH dream and say, let's take these technologies, these new fundamental understandings about behavior, about the brain, about our human biology and our genomes, and really put them to play where we need them the most. And that's beginning to happen. I mentioned the example of cystic fibrosis, but we've got spectacular kinds of advances in lots of areas of medicine. I often use the example of cardiovascular disease, where the rate of sudden death from cardiovascular illness is down 70% in 40 years. It's 1 million people a year who would have died of cardiovascular disease, who survive and do just fine and may not develop any problems at all. Our ability to help people who have acute stroke, 30% of them walk out of the emergency room. That was unheard of when I was in medical school. HIV, when this was first described, and even up until 10 years ago, 15 years ago, diagnosis of AIDS at age 19 meant that you had about 18 to 24 months of life, sometimes 36, but you had a very shortened lifespan. Today, someone who gets a diagnosis of HIV infection, or if they even develop AIDS at age 19, they're probably going to die of some other cause in their 70s. So we have really seen extraordinary progress in some areas. But what I want to talk to you about is an area that is still very much a challenge, and in some ways is the next big frontier, both for the discovery science and for healthcare. And that's the issue of mental illness, which is probably something that in this room we've got some people who know an awful lot about and some people who know something about it because they've been affected by someone in their family or someone that they care deeply about, but it's not something they ever really wanted to know about. And I want to use this opportunity to kind of marry the two groups that are here and make sure that you know together about some of the issues from where I would see them, which is looking at what's the challenge that the nation faces with respect to mental illness. First point to make, and I'm just going to run down some numbers with you because I think you need to hear these, and we don't hear them enough. These are illnesses: depression, schizophrenia, autism, bipolar illness, PTSD, and go down the list. There are not a lot of them. There are about 12 that cause enormous disability in this country. When the World Health Organization tried to say, well, what are the medical sources of disability? What's really causing the most problems? I mean, is it heart disease or pulmonary disease? Is it cancer or diabetes? They didn't expect this, but what came out, especially in developed countries like the US and Canada, that neuropsychiatric illnesses trumped everything else. 30%, 28% of all disability from medical causes can be related to neuropsychiatric illnesses. Now, some of you will say, that doesn't make any sense. I mean, heart disease, cancer kills more people. But we're talking about disability, which has to do not so much with mortality, but with illnesses that are chronic and that take you out of the workforce or keep you from being able to function. And what makes mental illnesses really different from heart disease and cancer, and in some cases pulmonary disease, is that they start early in life. 50% by age 14, 75% by age 25. These are, in fact, the chronic diseases of young people in America. These are the chronic diseases of young people, no question about it. And they're incredibly common. Serious mental illness, meaning really disabling mental illness, affects about 7% of the population and takes people out of the workforce for life, which is how you get to 28% of all disability from medical causes being at our doorstep. So that's disability, but these are also fatal, which is something that people don't realize. There are 36,000 suicides every year in this country. And again, I know it's hard to put that in context. I mean, if it helps, you can say that in the 1 hour that we'll be here, there will be 4 suicides in the United States. And every one of them will have some 11 victims or 10 victims who love that person, who are connected to that person, and who had no idea that this was about to happen. And they will blame themselves for the rest of their lives that they didn't do more. But to put it into a kind of population context, 36,000, that is twice the number of homicides. Now, I would challenge you to take the newspaper or the TV reports of the last month and compare the number of mentions of homicide to suicide. No one would imagine that suicide is twice as common in America as homicide from looking at the evening news and the morning paper. And yet it is. Not only that, suicide is more common as a cause of death than traffic fatalities. And we have invested an enormous amount in our country to reduce homicide through the criminal justice system, and we've been quite effective. It's come down 30 to 40%. We've invested a huge amount to reduce traffic fatalities. We have a whole national traffic safety program with mandated seatbelts and speed limits. And in fact, the rate of traffic fatalities has come down about 30 to 40%. What have we done to reduce the rate of suicide? Relatively little. And in fact, the rate has not come down at all in 2 decades. It's just about where it was 20 years ago, except in places where it's gone up. And where are those places? Most strikingly, right now in the U.S. Army, where we have a doubling of the number of suicides from 5 years ago. Today, last year, the year before, we lost more soldiers to suicide than combat. This is a significant national public health emergency, which nobody's talking about. We don't think about it. And 90% of the time, it's related to a mental illness. Most of the time, it's preventable. These are illnesses that are treatable, and we're not doing what we can do to save lives. So very significant morbidity, hugely significant mortality, and it's worse than that because these are incredibly expensive illnesses. The average life expectancy for someone with schizophrenia, bipolar illness, one of these serious mental illnesses, is about 25 years early. They die in their mid-50s, not in their late 70s the way the rest of us will. And they don't die of suicide. I mean, 36,000 of them may in any given year, but actually most of those deaths are due to medical causes. These are the people who develop chronic pulmonary disease. These are the people, because 44% of cigarettes smoked in the United States are smoked by people with schizophrenia and bipolar illness. These are the smokers. These are the people who develop diabetes, to some extent because of the medications they're on, to some extent because they're more prone to anyway. These are the people who develop a whole series of severe chronic illnesses that kill them and that cost everybody a huge amount of money because 80% of the care is done through Medicaid or on public dollars. So we're all paying for this. Overall, the mental health part of the coverage is about, we think, about $318 billion a year, $1,000 for every man, woman, and child in the United States. A little bit expensive. That's just a small fraction of the real cost, because that's the cost of their mental health care. The big costs come from other kinds of health care that they require, often don't get, but other kinds of social costs, what the so-called indirect costs that are very hard to get your hands around. The fact that people with serious mental illness are a huge part of the homeless population in this country. That people with mental illness are the large number of the school dropouts, believe it or not, in this country. And that, in a way which is absolutely unacceptable, people with mental illness have increasingly become the individuals who, when they need to be institutionalized because they're psychotic or because they're very ill, end up going into the criminal justice system and not into the healthcare system. And those are costs that we don't even count in that $300 billion plus number. This is amazing. And it's particularly amazing because 160 years ago, we were able to finally take people with mental illness and say, hey, they have an illness. Let's get them out of the penal system and put them into the healthcare system. And we did that. Very successfully now, we're going in the reverse direction. In the United States, if you have a serious mental illness and you need a bed to be treated, you are 3 times more likely to end up in jail or the prison system than in a hospital. There are very few beds. The state mental health system, which was there for a long time as a kind of safety net, has been shredded by 90%. So we've got a massive reduction and yet a continuing and in some cases increasing need. And that 3 times more likely to be incarcerated number that works sort of overall. But if you happen to be a young African-American man who's got some paranoid issues and has a psychotic illness, your chances aren't 1 in 3 or 1 in 4. You are going to be almost certainly ending up in the criminal justice system instead of in the healthcare system, where your care is not going to be as good as it could be. But the sad fact here is that even if you end up in the healthcare system, your care is probably not going to be as good as it needs to be. So we're at an interesting point in time where we've got, on the one hand, this extremely promising revolution in biology and in cognitive science that are allowing us to think about all kinds of new opportunities for diagnosis and for treatment and for completely revolutionizing the way we help people who have mental illnesses. On the other hand, we're dealing with a set of disorders which are treated in a way that's very, very different from the rest of healthcare. We already generally talk about this as the behavioral health system. And so I'm going to leave you with a thought, because I know this is a group in which about half of the people here are coming from the Woodruff Foundation, which has made such extraordinary investments, very strategic, intelligent investments to try to help in supporting behavioral health. This most recent one to Dr. Horvath, which is to actually make sure that people in the criminal justice system are getting the kind of mental health and physical health care that they need. But I want to suggest in a rather provocative way that even that concept that we have of behavioral health is not where we want to be. This is one more case in which separate is not equal. We do not want to get better and better at behavioral health, because where I think the science is going is it's telling us that these are health problems. Yes, they involve the brain. Yes, they involve behavior. Yes, they have huge social implications. But you know, diabetes and heart disease and dementia, a lot of those also have huge social implications. We don't benefit by cutting our approaches to this, whether they're the scientific approaches of discovery or the health approaches of providing care. We don't benefit our patients and their families by splitting them off and by thinking about how to pull together the safety net that we need. We need to do that now. We need to do that quickly to the extent that we can. And with healthcare reform and parity, we need to make sure that we build the net that needs to be there. But going forward, the vision has got to be some way of integrating care and looking at people with mental health disorders the same way we think about people with diabetes, the same way we think about people with cancer. We don't allow the disorder to define them. We serve the person, we treat the whole person, and we make sure that we have the systems of care in place and the continuity of care in place to help them through what is a very difficult challenge of managing a chronic illness. We have to get to the point where we stop separating this out as an altogether unique and different kind of illness. So I do think that hopefully I'll convince my wife that her wildest dreams could involve something other than whatever they might be, and that they may in the future include me as well as whoever else she's dreaming about. But in the meantime, what I wanted to suggest to you is that what we have for us is a challenge to face. This is expensive. It affects all of us. It is going to require a village to be able to fix it. By bringing together the Woodruff Foundation, the City Club, the leadership of a community, we can do much better with the treatments we have now. And I think for all of us, the challenge is there to think about how to do this in a way that serves those who need it the most. Thank you very much.
Today at the City Club of Cleveland, we're listening to a forum featuring Dr. Thomas Insel, Director of the National Institute of Mental Health. We will return to Dr. Insel in a moment for the traditional City Club question and answer period. Please do formulate your questions now. Remember to keep them brief, please. We remind you that everyone is welcome to attend City Club forums And we hope all of you here and all of you listening, if you're not already a member of the City Club, will join the City Club. We can use your support. We welcome all of you here and those listening to WCPN 90.3 FM, WCLV, WTAM, or one of the many radio stations across the country. Our television broadcast partner is WVIZ PBS Idea Stream. Television broadcasts of the City Club are made possible by Cleveland State University and PNC. Our live webcast is supported by the University of Akron. This year, 2012, the City Club of Cleveland turns 100 years old. There's lots of exciting activity this year. Several programs are scheduled, including the second in our Encore Speaker Series, April 18th with John Dean, former White House counsel to President Richard Nixon, and another Encore Series the following week, April 26th, with Jim Wallace, Editor-in-Chief, Chief Executive Officer of Sojourners Magazine. We would like to welcome guests today at tables hosted by Baker Hostetler, Case Western Reserve University Department of Psychology and School of Medicine, the Mandel School of Applied Social Sciences, and the Woodruff Foundation. Thank you all for your support. Today's program is sponsored by the Woodruff Foundation and in partnership with Case Western Reserve University. Joining us today at the head table is Richard Paulson. Will you please stand and be recognized? We're also pleased to welcome students today who are here as part of the City Club student program. Participation of these students is made possible by a generous grant from the Cleveland Clinic. With us today are students from North Royalton High School, Max Hayes High School, Brush High School, and John Marshall High School. Will the students please stand and be recognized? Now we'd like to return to Dr. Insel for our traditional City Club question and answer period. Holding the microphones today we have Carrie Miller, Program Director, and 100th Anniversary Assistant Director Betsy Wallace. First question, please.
Hi, Doctor. Welcome. I do a fair amount of work in juvenile court as a guardian ad litem, and often work with troubled kids and families. And what you said about mental health is a very acute problem in those families. I wonder if you could comment about the state of research involving of using prescription drugs on kids, and because it often seems we have wildly differing results with some of those sort of treatments.
Let me just make sure I understand the question. So in terms of the treatments for drug abuse in children, or the
level of research that gets done about
Sure.
drugs on kids, and then the treatment programs.
Right. So as I started off my remarks by saying that I'm from the federal government, and one of the things the government does well is to segment problems. We actually have a different institute that's focused just on it's called the National Institute of Drug Abuse, focused just on looking at that specific problem and supporting research to try to understand both how to prevent substance abuse and how to treat substance abuse, especially in adolescence. So
I'm not talking about drug abuse. I'm talking about schizophrenia among youth, things along those lines, and how do we, because it often seems that they're treated with adult drugs and we get wildly differing results.
Okay.
I'm sorry for the confusion.
Thanks for clarifying that. So if the question is about the use of antipsychotics or drugs that have been developed for adults and using them in children, there's a fair amount of research in trying to understand what works best in kids. Now, there had been traditionally a difficulty in being able to support research on children, huge concerns about safety and about informed consent. I think a lot of that has now been overcome, and I think the FDA is far more supportive of making sure that we demonstrate that something is effective in children before we just assume that whatever has worked in adults should be used in children. What we do know about the class of drugs that are in this general family, particularly the antidepressants and antipsychotics, is that they can be effective in children. Generally, the dosages need to be very different, and the side effect profile is quite different. And one of the places where we've been most challenged by this, as you probably know, is that antidepressants, which are generally used to reduce the rate of suicide in adults, in some studies appear to actually slightly increase the risk of suicide in adolescents. I don't fully understand why that would be, but it reminds us that we have to actually do the studies. We actually need the science to demonstrate what the effects and what the adverse events can be in this different population.
How do you deploy, how do you prioritize the deployment of those immense resources in NIMH and the NIH to take advantage of all these new technologies to actually start dealing both in the present and in the future the various problems that you described?
The challenge is always to figure out how do you use the funds that you have in a way that has the biggest impact. And whether you have 1.5 or $150 billion or 150 million, it's always this question of what is the most important investment and what are you trying to accomplish? In our case, and we're about 5% overall of the whole NIH budget, so we're a smaller piece of that, so we're $1.5 billion. We look for both long-term and short-term needs. And on the short-term needs, we ask ourselves, what's the nation facing? If suicide the rate has doubled in the Army and we're losing more soldiers to suicide than combat, we need to be there. And we need to think about what we can provide to the Army to change that. We've got this incredibly fragmented system for people who've had a psychotic episode. We actually have exceedingly good psychosocial interventions, things that are called assertive community treatment, supported employment. We have a whole range of things that really do work for that population, but we don't do them. We don't pay for them. We don't have them integrated in a way that makes it easy for states to deploy those kinds of resources and to support them. So we have a role, and we can do a fair amount in the short term. At the same time, it's kind of like any big investment strategy. You have to think about long-term investments as well. And what is it that's likely to pay off, not so much in the near term, but in the long term, and finding the right balance. So the kind of research, that may ultimately provide a treatment for PTSD or for depression 10 years from now. That's the challenge, is what's the right balance between the long-term, short-term, high risk, low risk. And we do this as well as we can. Fortunately, the way we do it is to bring in a lot of people to help us. So a place like NIMH has a council, an advisory council, Dr. Faye Gary, who's here, and has been a close advisor, a close friend over the years, has been one of the people who's helped us to keep our eye on the prize and to help us. So she will tell me, you know what, there's a lot of short-term needs here. You guys just don't know about them. And it allows us to then make sure that we're paying attention to what we need to pay attention to. So it's a strategy that involves a lot of stakeholders, a lot of very careful planning, and has to be built with some ability to turn funds over quickly. So if you make a mistake, you don't continue to pour money into something that's not paying off.
Dr. Insel, one of the fundamental needs of dealing with a mental health problem is to be open to it, to see it, to talk about it, to address it in yourself or a family member or a friend. And one of the impediments in accepting that need is that mental health issues touch so closely on our sense of self, such that to admit you have appendicitis is no big deal in terms of what your personality is, but to say, well, I am suffering from depression, suddenly changes who you are. So do you have any counsel on how to loosen those binds and get people to become more comfortable to speak openly about their mental challenges?
Well, I'm old enough to remember when we talked the same way about cancer. So when I was a medical student, the word cancer was not something that anybody used. In fact, I remember my very first patient at the VA hospital in Boston who pulled me aside and said, "Doc, you can tell me, do I have the big C?" And I thought, what is the big C? What is he even talking about? There was a time when there was this real fear of saying the words. We're still there, I would say, for disorders like depression and schizophrenia. And part of it is exactly what you touched on. In some way, we've conflated having the illness with who we are. We don't do that anymore for cancer. We don't do it for most medical problems. We're able to say, I've got diabetes. We don't say, I'm defined by being a diabetic. But in the case of mental disorders, there's still this problem of having that become the definition of who we are. Even though we've seen people who have schizophrenia as a disorder and have gone on to do spectacular things. So one of the ways I think we can help is to tell that story much more often and to help all of us separate out the illness from the person, and even to talk to the people who are struggling with these illnesses in just that sense, saying, this is not who you are, this is what you have, and we will help you to overcome what you have to become who you really are, which is a lot more. One of my mentors when I was growing up in this field said to me, if you tell me somebody has schizophrenia, you've told me about 10% of what I want to know. And I think that's the kind of perspective on this that we need to continue.
Dr. Insel, I was very impressed by your description of where genomics has gone, and particularly brain imaging, which I didn't realize had gone as far as it has. My question has to do with treatment modalities for mental health, and it seems that the progression has been in the last 20 years at least to go much more heavily to the psychotropic drugs and meds being a primary intervention and not so much behavioral change or counseling type things, though that's usually involved. Does the research and the brain imaging possibilities lead us to find ways to be more healthy that will improve our mental health or to help people stay more mentally healthy without using drugs, is my question.
Yeah, I love that question. So thank you very much. I think, I told you that we've had this suicide rate that hasn't come down, and we have had various measures of mortality and morbidity where the outcomes are just dismal relative to other areas of medicine. What I didn't say, but was sort of implied, was that's at the same time that we've had this exuberant use of medications. It's a little hard for me to believe that the medications are as effective as the pharmaceutical industry advertises if you're not seeing the public health outcome. By the way, that would not be true in areas of infectious disease or cancer. So I can tell you that, if we use antiretroviral drugs, we will reduce, and we have reduced, the transmission of HIV 96%. That works. We can show it. And it's not the case so much with the medications we have. They may be helpful for some people, but they're not helpful enough for all people. And they allow a lot of people, I think, to get somewhat better, but not very many to really recover. So one of the things that we would hope is going forward, we can use these tools, both the genomics to help understand who's going to respond to what, and the imaging to use that to kind of identify new targets for treatment development, some of which will be cognitive. We have a lot of interest right now in how could you use video games to help kids who are at risk for schizophrenia to become resilient instead of being vulnerable. I talked to you about how the brain is so adaptable and it responds so much. So you've got taxi cab drivers who have big areas of their brain, their hippocampus, that grows up larger to take care of geography. What if we could identify the circuit that is at risk in schizophrenia and provide the video game that would help? Kids are going to play these 8 hours a day no matter what we do. We might as well give them something to play that will help them. It's like what you would do for somebody who you wanted to be a basketball star. You'd have them practice. And practice could help us there. And I think brain imaging could be one of the ways to lead us towards these other treatments. I wouldn't rule out pharmacological treatments in the future. I think we can do much better than what we've done now. But these tools will be one way to get there.
Thank you for being here today, Dr. Insel. We often classify mental differences as disorders or disabilities. Autism, ADHD, depression, bipolar disorder, all forms of these differences. These traits have definitely persisted throughout generations. Is it possible that we are missing maybe the positive genetic reasonings for these traits, just as the sickle cell fitness benefit with malaria?
Yeah, it's a great question. It may be that the genetic risk factors that cause something to be perpetuated from generation to generation will, in fact, also be factors that confer some benefit or some what we would call a survival advantage. It's not clear that that's the way this will play out. I think the science will help us to understand that. The best sense that we have, actually, is that disease like autism has very, very markedly reduced fertility rates. And so it's probably not as simple to say that the genetics here would have been conserved or preserved in the way that the genetics for a disease like Alzheimer's, which happens very late in life after you've had your offspring, might still have a kind of conservation or even some advantage. That tells us that perhaps the genetics is very different, and I think it is. It turns out that these are probably much rarer and much more deleterious lesions when we find them. But I would sort of reframe your question a little bit. I think that it's important to remember that even though we may think about these as traits, and they are, in fact, they are traits that are found in the general population. And so there's a way in which people with autism are on a continuum with those who are just less social, with those who may be loners and may have actually tremendous gifts. I think we have to be careful, though, not to minimize the severity and the disability and the fact that at the end of the continuum where we are focused, we're talking about something that is truly disabling. After all, you could say the same thing in virtually any medical disorder. I mean, diabetes is, in fact, on a continuum with the way that we regulate glucose. And hypertension. We all have a blood pressure. We've just made a decision about where we're going to make the cut that will say this is somebody who has hypertension and instead of just having a slightly elevated blood pressure. I think we need to do the same here. I think the real threat for us has been that the people within the field have been reluctant to embrace how serious, how fatal, and how disabling these illnesses, and I think we best call them illnesses, how serious they really are. And I wonder at times whether part of the reason that we've had such difficulty in making progress is because of us, because as a field, we have shied away from recognizing that these are serious disorders that need serious interventions and need serious science to go with them. So I would caution, as we think about these continua, that we don't give up the idea that at the end that we're focused on here, those with serious mental illness, these are tough, fatal problems that are going to require every ounce of energy to solve.
Good afternoon, Dr. Insel, and welcome to Cleveland. I'm curious about the studies that have been done on the implications for medication for the minority population. Unfortunately, there's a disproportionate number of minorities in the prison systems, in the child welfare systems, and they are being medicated at younger and for longer periods of time. Are there any studies that look at the way the body responds to those medications, psychotropic medications, for minority populations?
Great question. Of course, a lot of this has already happened in areas like hypertension and diabetes. We have a lot of awareness that there is something about race and ethnicity that determines response. I even heard an extraordinary example of this the other day, that we use factor VIII for people with hemophilia. So we're using actually the protein that was a human protein from volunteers. Except that when factor VIII is purified, it's usually purified from white volunteers. And when it's injected in African Americans with hemophilia, they actually develop antibodies, and it makes them, to some extent, worse off than better off, until we recognize that there are these important differences in our biology that we have to get much clearer about. In the case of mental illness, what you said is exactly the case. We, often that there is, and we have the data to demonstrate higher rates, higher doses of medication, often the fact that people with African Americans in particular are more likely to be in the criminal justice system than in the healthcare system. But contrary to what you're saying, and actually perhaps even more worrisome, is that when you look at the rates of any kind of care, that really divides by racial and ethnic lines. That is, that African Americans and Latino populations are less likely to get quality care. And the most vivid example of this was earlier this year when we studied what happens to children with autism when they come out of the period of school support. So looking from age 18 to age 23. And what you find is that there's about a 50 or 40% reduction in the number of people getting continuing both behavioral support and social support and occupational support, except for African Americans, where there's about an 80% reduction. So we've got this enormous disparity that we already know about. Now, how to fix that disparity turns out to be a much harder problem, and it's one that we're focused on. But that is, unfortunately, I think, one of those longer-term challenges, because it's not one that so far has responded to anything that we've tried.
That's great. Today at the City Club of Cleveland, we've been listening to Dr. Thomas Insel, Director of the National Institute of Mental Health. Thank you, Dr. Insel. Thank you, ladies and gentlemen. This forum is now adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.